I think one of the most painful lessons I personally learned during the pandemic was the lack of trust that public health officials and agencies have about digital technology. And I think it's rightfully so, right? Like there have been decades of underinvestment in these critical agencies. And so what we're launching in partnership with OpenAI and Anthropic is a massive effort to develop a set of playbooks on how best to use generative AI tools for specific public health use cases.
Welcome to How I Doctor, where we're bringing joy back to medicine. A few years ago, a pediatrician named Brian Anderson was standing inside Mass General Hospital during an EHR rollout, watching a system that was supposed to help him take care of patients start eating into his life instead. That experience pushed him out of the exam room and into a much harder question. How do you get a clinician to trust a piece of technology they didn't build themselves and can't see inside of? His answer, more or less, was a nutrition label. Not a metaphor, but an actual document. Dr. Anderson co-founded the Coalition for Health AI in 2021 and has spent the years since trying to build something you could flip over and read the same way you'd read a can in a grocery store, except this was for AI tools sitting inside your EHR. Today, we're going to get into a little bit more of the transparency and what it takes to build a coalition with so many stakeholders who might not always agree on shared values. And more importantly, what a doctor with no data science team and about 90 seconds between patients should do the next time someone hands them a new AI tool. I'll be right back with Brian after a quick word from our sponsors. Before we jump into the episode, I want to thank our sponsor, Evidently. Evidently is the clinical data intelligence platform built to help physicians harness the ocean of patient data they're drowning in every day. From chart summarization to AI-assisted note drafting and denial appeal support, Evidently makes sure the right data shows up at the right time. Physicians using Evidently report spending less time hunting through charts and more time focusing on patient care. That's why they've become a trusted partner to health systems looking to improve documentation, quality, and revenue sustainability. The company is led by providers and AI researchers that are dedicated to reducing documentation burden and helping clinicians practice at the top of their license. If you want to see what Evidently can do for your hospital or your practice, reach out today at www.evidently.com. Now, let's get into today's episode. The next generation of physician innovators are already thinking hard about AI in clinical practice. Off-Call teamed up with MD+, a nonprofit community of physicians and med students across the country, to write the guide I wish existed when I started trying to make sense of all of this. It's called The Physician's Guide to AI, a practical primer across specialties. 9 specialties, 40 plus physicians, and it's completely free. Search for it now in the Kindle store or visit offcall.com. Dr. Brian Anderson, welcome to How I Doctor.
Great to be with you, Graham. I've been looking forward to this.
Can you take us back to the beginning? What pushed you out of the exam room and into the metaphorical building technology room?
So I grew up in a very rural community on a reservation in southwestern Colorado. And I had, for some reason, as a young boy, this desire to want to be known and want to be, connected and part of a community. And so this desire, I think, is what started me on this journey of wanting to be a physician. I saw being a pediatrician, a primary care physician, as a path to being that kind of member of a community. One, I love kids. And taking care of families and their children seemed like a pretty noble cause. That was the naive perspective of what practicing medicine looked like. And then really getting into the brass tacks of it in an institution like MGH, Massachusetts General Hospital, which is fantastic, was a revelation of a completely different kind of medicine, a kind where there is incredible time pressure, where you don't get to spend enough time with patients as much as at least I wanted to, where the computer technology that we were using back then was so clunky. It was really hard. I'd done a little bit of computer science as an undergraduate. And so seeing how poorly built these EHRs were, I believed that there had to be a better method. And so I naively again thought I could solve it all by going into private practice and being my own physician. And I would choose my own EHR. I think the only EHR at the time that was internet based was an EHR from a company called Athena Health. And I
Yeah.
got excited about an internet based EHR and looked into that, was about to go forward with them. But a friend of mine said that they wanted to hire a physician to help lead their product development of their EHR. And then next thing I knew, I wasn't practicing clinically full time. I started building a team in digital health that then turned into a set of teams in the AI space. And next thing I know,
Now we're talking today on a podcast. Brian, I think that that concept you said several times of just your naivete around what medicine is actually like. I giggled a little bit when you said it because I had the exact same experience. And I almost wonder if that's a required step for someone to be able to make change or impact the system is to have that washed away from you and like get the real deal of what it's like as part of your medical training or your residency training of just like the optimistic glasses half full gets washed away or knocked over on the table, and you get
totally.
like the real thing thrown in your face
I mean, I
sometimes.
remember in medical school and residency, no one talked about burnout. I mean, people talked about long hours and how hard it was. But burnout, just the other year in my class at Harvard, we said goodbye to a colleague of ours who had taken his own life. And you don't connect all those dots about how broken this system is when you're in medical school. And maybe you begin to get a little bit of a taste of it in residency. But in some ways, I wish I had learned about that earlier because it would have motivated me to maybe go down this path that I'm on now
Yeah.
sooner. I wish that I had learned how to use some of these technology skills earlier on to help, potentially solve that mismatch. It gives me hope that, AI technology is going to help solve that. But I mean, I think a lot of work still needs to be done, obviously.
You mentioned the word hope around like people hoping that generative AI will help with a lot of these challenges. And then I wondered, like, well, is that naive too? Is that hope naive, and that the real answer is going to be just way more complicated? Hopefully, it's not. Doesn't involve as much burnout and strife and long hours and pain and all that, of course. But just is the challenge to get generative AI right in medicine, is that going to be tough as well?
Hope that one of the things that comes from the use of generative AI in health is the creation of more space for patients and doctors and people to connect. There was an interesting New York Times article a few weeks ago about how ambient listening is going to be changing the way doctors learn, right? The way that we connect with patients is by, in some ways, listening to them and laying on of hands of them. And I see generative AI certainly helping us to be able to spend more time doing that. And at least for me, and I think probably a lot of physicians, like that's why we got into medicine is not to, stare at a computer screen and type in our notes, but to be able to really connect and kind of do that cognitive thinking about, well, how can I help this patient? What's the diagnosis? What's the assessment and plan?
That is the most positive feedback I have heard from physicians across the board using generative AI, and in particular, kind of ambient listening
Mm,
generative AI.
yeah.
And it's also the most qualitative, which means it probably doesn't show up on any dashboard for any health system or anything like that. Clinicians telling me the thing I really like about it, and I think it takes them a few weeks to get into this habit that they trust it, but the thing I really like about my AI scribe or my ambient listening is that I can be more fully present with the human being because I'm not having I'm still doing several things at once. I'm still doing regenerating my differential in my head. I'm still figuring out what question to ask next. All of those additional systems are processing, but there's one less system of like, oh, I need to make sure to memorize, commit to short-term memory how many days they've been sick and what their actual story is so that I can then write it down correctly. And so just being able to take that piece away from the physician CPU and allowing them to be like, "Oh, I'm not worried about memorizing their exact story, that I can just talk with the human and listen to them and hear what their symptoms are, that I think physicians love that they're like, "Oh my god, I can actually be a little more human with my human patient."
If the job of a provider is to help a patient live a healthier, more flourishing, more complete life, like I have to understand you in as full and a holistic way as I can, right? It has to go beyond the lab tests that you got or the vital signs that I have in front of me. And to be able to do that, to spend that kind of time to understand you in that holistic way, you have to listen, right?
Yeah.
You have to be present in the moment. That's what really excites me about AI in healthcare is the physician that is freed to be able to do that.
A quick word about today's sponsor, Evidently. Their platform turns an ocean of fragmented clinical data into concise, actionable insights. Chart summaries, note drafting, denial appeal support, HCC capture, so you spend time caring, not chasing. A transplant surgeon at a large academic medical center recently took transplant referral review from 2 hours to 20 minutes with AI-assisted chart review from Evidently. Physicians deserve workflows that improve accuracy, reduce exhausting chart biopsy, and help us practice at the top of our license. If you want to see how this might work in your hospital or your department, go to evidently.com. That's evidently.com to get started today. Brian, let me just ask you a little bit about chai now, because I think a lot of people probably some listeners know about chai and some have heard of it, and then some people don't even know that I'm not talking about tea. For listeners who aren't familiar with the Coalition for Health AI, can you give us an overview? Maybe if I'm a practicing clinician and I have no interest in AI whatsoever, what does chai do? What are the impacts you guys are trying to have?
So back in March of 2020, I had been asked to help lead some of the data analytic efforts under the White House COVID Task Force in Operation Warp Speed. And in that space, we were obviously all focused on the pandemic, but we were using AI a lot. And I still remember many instances where you had the same set of data that you would feed into different models, and you'd get wildly divergent outputs. And that begged the question, why? Why are we
Yep.
getting different outputs? But it also begged the question, do we have consensus on what good, responsible AI looks like? Answer we quickly came to is no, we don't. We have a lot of good work happening in different silos, but not a consensus kind of set of best practices. And in a consequential space like this, like healthcare and in the pandemic, I think we all realize like, gosh, like this would be something that we're focused on. So it was initially started as a side project in the pandemic, bringing together the public sector and the private sector, trying to build this consensus of like, what are the guidelines and guardrails or the best practices for how we build AI to be used in healthcare. It started with 8 organizations, and now it's quickly grown to like over 3,000. And that North Star still remains though, right? We want to bring people together, organizations, and building in a consensus-driven manner. What are these best practices? And how do we take these principles at a 50,000 foot level, like transparency or fairness, and actually drill down to get to the ground level of like, what does that actually look like? And so what we've done is brought together the developer community and the deployment community, health systems, doctors, and nurses, and said, okay, if a doctor is ultimately the one accountable for the use of any tool that touches a patient, that doctor should know about the quality of that tool. So we had doctors saying, yes, this is what I need. I need this kind of data. And we had developers saying, we want to be good partners to our customers, but how do we do that in a way that doesn't reveal our IP? And so, it's not a perfect thing. I'll be the first to admit, Graham, that these model cards, they work really well in like the procurement space where you have hospital administrators making big procurement decisions about, do I spend millions of dollars on this vendor or that vendor? I think the challenge that we still haven't answered yet is, well, what about that physician that's about to walk into that exam room that only has 15 minutes? How do they think about the tools that they're using? Because part of the challenge, right, you and I, we're trained, we know how to use stethoscopes. The vision is bringing together those voices the physician voices, the nurse voices, the developer, the technology company voices, the patient voices, and coming up with these standards. And then I think, and this is one of the really cool things, is once you have a common definition of what good looks like, you can then develop a set of metrics on how do I evaluate a model's performance, right? How do I think about, is this thing working good or is it not working good? Is it sort of just all hype and there's no real performance benefit? I think one of the exciting things is you can hold a level of accountability when you have a common definition of what good looks like. You can hold the developer community accountable. You can hold providers and hospitals accountable to the performance of the model.
Okay, Brian, $1 million question. As the CEO of Chai,
Uh,
how do you get different stakeholders to agree on what good looks like? Because that looks both two stakeholders can have completely different opinions and both of them can be right, but you've got to pick a standard. How do you build that coalition?
well, your listeners might not be able to see all the gray hairs that I have in my hair, but it's certainly not easy, Graham.
Yeah,
When
yeah,
we launched Chai, we intentionally did not want to make it just a provider organization.
yeah.
We did not want to make it just a technology company organization. We wanted to make it this big tent approach that brought together all these stakeholder groups. And I think we appreciated that there's going to need to be compromise. Finding the common ground where there's alignment of incentives
Yeah.
has been how we've been able to build some of these consensus perspectives, right? Vendors want to be able to sell to their customers and they want to build, meaningful, deep, lasting relationships so they can continue to sell to those customers and grow their market. Customers, health systems, doctors, nurses want to use high quality products. They want their patients to trust them. They want to deliver better clinical outcomes. As we make a movement towards, clinical outcomes and away from fee for service, there's
Yeah.
even greater alignment in that latter category. And patients, of course, want to have the best possible healthy healthcare that they can. And so aligning on those basic principles and then building up from there is how I think we've been able to accomplish what we've done.
You said more data is not always better. And I could not agree more with that. And I think that's actually really counterintuitive for a lot of people listening. Why do you think maybe that's not the case?
Give you a couple examples. When we were in the middle of the pandemic and we were urgently trying to collect data from health systems about COVID, we were literally getting all sorts of data. I remember it was on a Thursday that we just get this download of data from all the hospitals in America.
Wow.
And Graham, it was an absolute mess. Right?
Yeah.
You imagine you have different fields of how many patients have COVID? Well, you get so different numbers. What was the outcome? And the reason why it was such a mess is because everyone had different definitions,
Yep.
right? Well, whether or not this patient had COVID, when were they diagnosed? Did they die? Well, what does it mean? When were they intubated? Even things that we might take and assume as pretty straightforward, different people have different definitions of what that looks like and different context in how it was collected. And if you're trying to develop insights into as complex a thing as human physiology, it's
And
so
and a novel virus and disease.
and
Yeah.
a novel virus and disease, you really need to be very close to how that data was collected and the context in which it was collected. And was that data collected with the specific end purpose that me, kind of at the end of it, sitting in an office, had in mind? Or was it being collected for a completely different purpose by everyone running around with their hair on fire because we're in the middle of the pandemic? And of course, it was the latter. And so the data was a mess. And so trying to make insights out of that was incredibly hard. As we kind of race into this space of capturing more and more data, I think the importance of capturing real world data with an understanding of what the context in which the data was captured and the potential biases and confounding variables associated with that is going to be really important. And I think one of the really exciting things about this, Graham, and this may be going too much down a rabbit hole, is these concepts of inference models. I think one of the great things that excites me in the clinical research space is being able to use observational data with models that are trained or tuned in inference to be able to tease out the kinds of cause and effect that we have only up until this point really been comfortable using double-blinded, randomized
Yeah.
controlled, trials for, where we can, control everything. But what we learned again in the pandemic is that's great if you can control everything. But oftentimes, trials, obviously, they're by nature artificial. And so when you have the complexities of life stressing that, it makes it really hard. AI models, particularly inference models, I think offer a way to allow us to see through that and tease out the signals in that.
I don't think there's ever been a study where when you test an intervention in the real world, it's the impact size is ever as big as it is in a trial, right? It's like, oh, TNK for stroke, it works real well in the trials. It works less well in the real world because there's just human complexity, biology, realistic challenges of all that. Yeah, I completely agree. Brian, let me maybe just ask you about the two announcements that you guys are planning to talk about with Chai. Maybe I'll start with public health since we were just talking about the challenges of COVID data, health as well. Can you tell us a little bit about what Chai will be announcing?
I think one of the most painful lessons I personally learned during the pandemic was the lack of trust that public health officials and agencies have about digital technology. And I think it's rightfully so, right? Like there have been decades of underinvestment in these critical agencies. And so what we're launching in partnership with OpenAI and Anthropic is a massive effort where OpenAI and Anthropic are donating thousands of licenses for Claude and ChatGPT to Chai. We're going to turn around and then make those available to state public health agencies that want to partner with Chai and OpenAI and Anthropic to develop a set of playbooks on how best to use generative AI tools for specific public health use cases. Now, the exciting thing about this is that these models are going to be built and structured in such a way that PHI can be used. So we're going to be launching that and doing that pilot for 6 months to a year, and
Wow.
really excited about the playbooks that are going to be developed at the end.
That's amazing. I mean, Charity Dean in California said, hey, well, the best way to help public health systems is to get them more fax machines, which is a terrifying, but at the time, I think correct answer. So if we can do any better than that, Brian, I think I have to credit you with success.
It's a community effort, and I have to give my hat off to OpenAI and Anthropic for being willing to partner with us in this. And I mean, beginning to create the muscles that we need in our public health agencies to use these tools is going to be great.
Brian, I know you also have a cybersecurity project you
Yes.
guys are working on. What's that one about?
So back in April, I think probably most of your listeners are aware that Anthropic rolled out Mythos, their new class of models that had this amazing set of capabilities that I think scared a lot of people. And then there was a back and forth between the US government and Anthropic about making this available. Who should it be available to? Was it risky? Should we put export controls on it or not? The dust has begun to settle on that. So we're excited to actually launch a health sector specific version of what was started back in April. In
Wow.
April, Anthropic launched this effort called Project Glasswing. Many of the health systems in Chai said, "Hey, why aren't we doing something like this for health systems?" Health sector is critical infrastructure. It's the most attacked from a cybersecurity standpoint of any of the critical infrastructures. You have to just look at the ransomware attacks, the PHI leakage that is at risk and happening on a nearly daily basis to remind ourselves of the critical need to have robust cybersecurity provisions
Yes.
in place for all of our health systems. No one's done that yet.
That's
We saw
awesome.
the
I love
need.
it.
And
Yeah.
so we're going to be launching this. We're really excited about doing it in collaboration with some really big names. And the intent is to create a set of playbooks, operational cybersecurity playbooks, defensive strategy playbooks, a set of policy playbooks for the world. It's going to be an international effort. It's going to involve multiple governments, not just here locally in the US. And so we're really excited about doing this for the benefit of our society.
That's amazing. And I think we know that hospitals and health systems are often targets of ransomware attacks, and we know the impact on what happens when your EHR goes down or your entire phone system goes down. We've seen, unfortunately, dozens now of health systems attacked over the past, I don't know, probably 10, 15 years as well. So that's really exciting. Congratulations.
Thanks, man. I mean, it's a community effort. So we're just bringing people together to start doing this important work. Looking forward to it.
It's like you're the CEO of a coalition or something. You're so good at giving everybody credit, Brian.
Thanks, man.
Brian, what does success look like in these initiatives? Is it this is widely deployed? Is there lots of learnings that happen? Like, what do you guys consider? Hey, we did this thing and it worked really well.
The way I look at it and the way I'm trying to push our team is to look at impact. And so I think deployment and use or utilization like of these playbooks is certainly one part of it. I think the real brass wing that I'm looking for our team to reach for is showing how if these playbooks are used and the performance of an AI model or a cybersecurity strategy is measured, does it actually benefit the patient, reduce the risk of, PHI or whatever, ransomware? And so looking for those hard numbers of the performance of an AI model leading to an improvement in a patient's, clinical outcome is really what we're looking for. And, one of the things that we're going to be launching this year is a post-deployment monitoring network to actually begin drilling into these numbers. This is something that candidly we should have, started a year, 2 years
Yeah,
ago,
yeah.
as these tools have been, widely adopted, but we don't have that yet. And so we're looking to pull together health systems within Chai to begin sharing that so we can really look at that impact.
As a AI leader physician in the world, what's one habit that you'd want physicians to build before they start using AI, or maybe if they're already using AI, that they should have in their repertoire in order to use it better or more safely or more accurately?
There's this concept of human in the loop that I think everyone thinks like if I just build an AI tool where a human's in the loop, that's going to solve the problem and going to reduce, the risk. Physicians, I think, need to be trained and have the skills of like, what does that really mean, right? Like, I don't want to be a check box or check the box human in the loop. Like, I just see the AI recommendation. Yes, I, consent and agree with it. But like thinking critically, we talked about how the data was gathered. Well, how was the data gathered that was used as part of the input for this model? What are the biases for the model? Like really beginning to drill into some of the critical questions that we need to think about as providers, because more and more we are going to be the physician in the loop using these tools, but thinking deeply critically about how the data was captured, how the model was built and trained is something that I don't know if there are school classes in medical school about this yet, but I really think that providers need to begin learning that.
Yeah, I think the societies are starting to think about this more. I agree with you. I think med schools do. It- I think this generative AI adoption is going to make critical thinking skills even more important. If generative AI is making them worse, we actually need to double our effort into critical thinking and logic and reasoning skills so that we can make better judgments and make better decisions if generative AI is going to take a lot of the work of turning data into knowledge or information or whatever as well. Brian, what should a doctor read or think about before trusting a new AI tool if they've never maybe heard of a model card or if that AI tool doesn't have a model card for it?
Looking to trusted resources about how an AI model performs in patients like those that you serve is probably the most important thing that a provider should look at. Like if I am in a clinically facing role and I'm about to use an AI tool on a patient and I don't really know that much about this AI tool and I can't answer that basic question, is this tool appropriate for the patient I have in front of me? Like I wouldn't use it. And so being able to turn to the sources that you can get that answer, I think are really important. What are those sources? Well, I think first and foremost, if you're practicing in a health system that has done local testing and local validation, getting those kinds of insights is really important. The next one is, I think, really turning to your specialty societies. Specialty societies are beginning now to develop those resources for providers to turn to get some of those answers. I think really getting into that technical detail of the performance of these models in the patients that you are serving as a provider is a key area that every provider should be looking at and demanding, not just of the vendors, but of their hospitals, their health systems, and their specialty societies.
I had this thought where I like this idea of upskilling, right? We could make all pediatricians 10% better at pediatric endocrinology or whatever, right? But the challenge is generative AI doesn't know how to stop at 10%, right? And so, how do the societies and the specialties say, hey, here's where we think generative AI this model could improve a pediatrician's knowledge base, but at some point, you do have some threshold where you actually say, this really should be seen by a specialist. That's actually a new challenge that we will have is how do we know what's the upper limit of how much you want to upskill somebody and when are you actually starting to get yourself into trouble if you're trying to act as a pediatric endocrinologist just using generative AI, for example.
One of the real promises for AI is its ability to be personalized and meet you where you're at,
Exactly.
right? And so if I'm a general practitioner pediatrics physician and not the endocrinologist, yeah, I don't know what that 10% looks like. But
Yeah.
if I have an assistant, an agent that's helping me that I could have potentially the opportunity to tune to kind of give me the right amount of information, I think there's opportunity in that space. But yeah, I mean, I don't know the answer to a lot of these
It's
questions.
interesting,
Yeah.
right? Yeah. Yeah. Well, Brian, it has been an absolute pleasure to have you on the program today. It's great to catch up, and thank you so much for being here.
Well, Graham, thanks so much for everything you do. I think you're an inspiration to a lot of us in this space. You are a hero to many folks, and it was a real pleasure being on your podcast. Thanks for having me, man.
Brian, where can people find more about you and Chai and those new initiatives that are going to be coming out soon?
Yeah, well, much more importantly, to find out about the initiatives in Chai, www.chai.org is the best place to go.
Amazing. Dr. Brian Anderson, thanks for being here. Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.